what are the goals? What would be the goals of an ERAS program? I mean, you're setting this up,
Well,
right?
all right,
At a new medical school.
Well, ultimately, the goal is to shepherd the patient through his or her recovery from surgery in as timely a fashion as possible with as few problems as possible. Now, to do that, again, you have to get a large number of people involved because, as we've all said, there are so many people that touch the patients as they go through the process. Anyone can disrupt or redirect the process. And so everyone has to be on the same page. I don't think any of us can emphasize that enough. And I love what you said, Sanjay, about revisiting. Again, you've got to audit what you're doing because there will be successes to see, which will encourage people, but there will also be a lot of variations away from the protocol. And unless you recognize that and go back to try to readdress that and ask people, why aren't we doing this? What's the reason behind this? You have no possibility of going forward. And essentially, that's one of the hallmarks of value-based medicine is looking critically at what we're choosing to do, seeing if it works, right? Seeing how that affects the outcome. And ultimately, of course, that affects cost and value to the patients and to society.
Right. That's the basic definition of value-based care is outcomes divided by cost. So we obviously in this budget-neutral area that we are. So but the outcomes obviously have to be measurable.
Absolutely.
Right. They have to be measurable. So, Traci, when you look at, as Sanjay said, monitoring your data, monitoring your programs, what sort of metrics are you guys looking at Virginia?
Yeah, and I think that's very important too, is to establish a database or some type of way you can monitor the outcomes. So the primary thing we look at is length of stay. You'll find most enhanced recovery programs, that's the primary outcome. You can't look at length of stay without looking at readmission rates. It doesn't help anybody if you get them out of the hospital sooner, only to have them come back 24 hours later. You also want to look at complications. At Virginia, we reduced our postoperative complications by half, and that was primarily due to reductions in ileus and also surgical site infections, which has also been demonstrated time and time again. And in addition to that, you want to look at patient satisfaction. We use HCAP scores. There are other types of patient-reported outcomes that you could look at. And then we look at costs. So we started in colorectal. We have gone now to gynecology, thoracic, hepatobiliary, and starting orthopedics next week. And in all those, we've demonstrated substantial reductions in cost. In thoracic, we were just reviewing the data recently. It was $10,000 per patient reduction in 30-day total costs. When you calculate by the number of patients in the hospital, can be a substantial reduction.
So as you look at various specialties, because obviously one of the things that we'll have a big discussion on is postoperative ileus, but when you look at this into some of the non-anastomotic specialties where we don't have a GI anastomosis, obviously like joint replacement, thoracotomies, radical prostatectomies. So what are some of the commonalities as you develop programs for those individual surgical subspecialties that really do equate across the board for all specialties?
You know, I think one of the primary tenets is pain control. You know, there are huge side effects to opioids beyond just ileus, which is the primary thing that we worry about in GI surgery. The potential for abuse, the delirium in the elderly, orthopedic patient, potentially in thoracic surgery. So I think that's one of the primary tenets. But all the rest of enhanced recovery is really just common sense things that affect patient satisfaction, and it's the right thing to do for the patients. And that equates to improved outcomes in most all specialties that have been investigated.